for today. Lis Neubeck, who is Professor of Cardiovascular Health in the School of Health and Social Care and Head of the Centre for Cardiovascular Health at Edinburgh, Napier University in the UK. In addition, Professor Neubeck is also the Cardiovascular Clinical Network Lead of the National Health Service Research Scotland organisation and the Patient Forum Lead of the European Society of Cardiology. A cardiac nurse by background with over 25 years of clinical experience, her research focuses on innovative solutions to secondary prevention of cardiovascular disease, management of atrial fibrillation, and digital health to improve access to health care. And today we're delighted to hear from you, Professor Neubeck, about digital solutions for heart problems. So with that, Lis, over to you. Thank you. And if I could ask you to unmute yourself, that's perfect. Thank you.
Yeah, that's fine. I wasn't allowed to unmute myself earlier. And despite spending the last probably 15 years working with technology, I did try to switch off my background because I seem to be looking a little bit alien. So I hope you can see me, but apologies for the virtual background is not working for me at all on this end. But anyway, I normally do look like a human, so I hope that's not too distracting. So really, I wanted to go over what has been amounted to like 10 to 15 years of research in digital care for people with heart conditions. And just to say, I don't think I need to tell this audience, but cardiovascular disease remains a leading global killer. We know that 50% of cardiovascular hospitalizations are repeat events. So there's a real emphasis on needing to support people once they've had a cardiovascular event to reduce morbidity and mortality. Attendance at cardiac rehab does improve cardiovascular risk factors, quality of life, and morbidity and mortality. However, cardiac rehab is typically time-limited, facility-based, and conducted in groups, which means that globally, accessibility to cardiac rehab is poor. But the use of mobile apps, social media, and wearable sensors may increase access to effective secondary prevention. So the work that we've been doing has really been around developing technology to support people with a cardiac condition. And just to sort of recap on what digital health is in this context, it covers a range of different things, including e-health, which is using emerging communication and IT to improve health, and digital health technologies, which include both hardware and software solutions, including telemedicine, wearable devices, augmented reality, virtual reality, and of course now the use of AI in supporting people with their health condition. So I started researching digital health back in about 2007. And at that stage, we didn't even have mobile apps. So between 2008, when the first iPhone was introduced, and 2009, when Google Play started, we've seen an exponential growth in the number of apps that are available. And the typical timeline for app development is around 18 weeks. But when we think about that in a research context, we have quite a long time in terms of getting, first of all, funding to do this, then getting the ethics, then doing the recruitment and intervention, and finally analysis and publication. So we're talking about somewhere between 5 and 6 years for typical research studies to report. That clearly does not keep pace with the timeline of trying to do research in digital health. So we need to be smarter about digital health. That's a bit better. I'm less distracting now. Apologies for appearing that way, but hopefully that makes it a bit easier to see me and not as a flickering image in the background. So really just going back on to think about what else is a problem with digital technology is we have a number of negative messages that can be conveyed in mobile apps. And of course, some of the food companies have really been held accountable for this. McDonald's was particularly good at bringing kids into using this by creating games. There's also the potential for people to use digital sharing to try to encourage people to behave in a certain way. So we know in terms of anorexia, there's lots of pro-anorexic sites which tell people about how to avoid this. So we really have to be very careful and confident in the technology that we use. Now, when we're thinking about technology for supporting digital health, we need to think about how the technology can be convincing. So we talk about persuasive technology. And when we review technology, we found that not all that many apps have behavior change techniques embedded in them. And that's probably a reason why people don't engage with health apps for a long time. And behavior changes only occur then when people have sufficient motivation, the ability, and the right triggers to make change. So we talk about, in terms of technology, we think about things like Fogg's model, which is about having the right information at the right time in order to trigger behavior change. But it's likely to occur when an app's widely used and a number of core components and ideal features are present. The first thing is it needs to be simple. The more complexity you build into the technology that you're trying to use with patients, the more problematic it becomes. The more they need to click between different screens, the more challenges you'll have to keep people engaged. So it's a potential problem with co-design, because when we tend to do co-design, people tell us all the functions and all the features that they think they could possibly need. And if we build something like that, it's way too complex for people to actually use. So we need to do some rationalization about what sorts of technologies we build in order to keep those technologies usable for people participating. We also recognize that in general, credible sources are valued by patients. They like to see that the information is coming from a reputable source. They worry about commercialization of their data, so they want to know where their data is going to be stored. But in fact, they don't worry as much as we, as researchers and healthcare professionals, think they do. They assume that, at least as healthcare professionals, we can link all of their data. In fact, that's often not the case. So we need to think about being credible and relatable when we're designing these technologies. As I say, not many apps have behavior change nested within them, and we need to think about that when we're building things. If we're trying to encourage people to make lifestyle changes, we need to be making sure that there is opportunity to support behavior change. And behavior change is complex in people, and the more demands we put on them, the more difficult it becomes. So we need to give them the confidence that they can set a goal and move towards it. And to do that, real-time data is highly prized within digital technology. So if we can use data from wearables, use data from connected devices, then this becomes more valuable in terms of making lifestyle changes. And the data needs to be very much personalized. So personalization is important. We also believe that rewards are important. And if you think about the type of apps that you might use regularly, and this is probably the only time anybody doing a presentation will encourage you to take out your phone and have a look at it. Think about which apps you use regularly. Do they have leaderboards, for example, something like Duolingo? Do they have badges? Do they have small gifts? Why do you keep going back to them? It may be because they're social updates, and those are the apps we tend to use. We also tend to use things like travel apps, banking apps regularly, but most of us will have on our phone a whole raft of apps we've used once and never used again. So we need to think about the sort of, how do we keep people engaged in technology? And as I said, it needs to be personalized. So we can't throw everything at every person and assume that they're going to need it. People are very individual in what they need. So they need to be able to tailor these things according to their own personal needs. So it may be that some people need more information on physical activity, that some people may need more encouragement, for example, with smoking cessation, or some people may need more encouragement with medication adherence. And we need to tailor that and understand the reasons why people may or may not take up the activity that we're recommending. So for example, with medication adherence, it's not just about the prospective planning memory that we need in order to take our medications when we're supposed to, but also about the beliefs about medication and combating any negative beliefs. Statins are ones that have been very, very much in the news for being potentially problematic, and therefore people need to understand the rationale around these different medications and have any negative beliefs addressed. And we do think that social elements are likely to be really important. So people come back to different apps because they get some kind of connection with their community. And so that it is likely that social elements in an app are going to encourage people to come back again and again. Of course, the downside of that is that often people who share on social media platforms are sharing worst case stories. So we don't always get the individual who's telling a more middle of the road story. We get a very dramatic story, and that convinces people that their condition needs that sort of level of problem, or that, you know, maybe that they're going to have more problems than we'd necessarily expect. So we do need to have a moderator on any social elements we create within this technology. Privacy is important. We know that we need to keep these apps secure. We need to ensure that any data that we gather from this is used in a responsible way. We also need to make sure, for example, if we're using geo-tracking, that it's not publicly open. There have been cases where, for example, military bases have been identified when people have been using their apps to track their physical activity. Strava was one that was particularly implicated. They're using Strava to track their physical activity, and people were able to figure out where they were. So probably less likely to be a concern of our patients, but people do worry about their privacy and their security when they're using these kind of apps. And we certainly don't want people feeling unsafe because they've given us their information. So when it comes to, this is a question I get asked time and time again, is can older adults use apps? Well, we know that apps in older adults have been successfully used to improve physical activity and cognitive function, but there are certain challenges we need to be aware of, particularly when we have complicated data usage plans. We also might need to design to use tablets rather than smartphones just because of declining vision, so people aren't necessarily going to be able to see what we put if we put it in small writing. But we know that at least 75% of users aged over 65 have downloaded an app to their device. But apps need to be developed for declining vision. And one of the surprising things that we discovered around the use of digital apps was that they still prefer a traditional old-fashioned user manual. So we started off building these wonderful videos to tell people how to use them, and they weren't used. They really wanted to have that printed manual that they could slowly refer to. And then just to move on to wearables, wearables add an extra dimension to physical activity monitoring in people with cardiovascular disease. So when we think about the components of physical activity, we tend to measure physical performance and exercise capacity. So we use tests like the 6-minute walk test and so on. But what we don't record is habitual physical activity. And actually habitual physical activity being one of the most important components of physical activity. No single measure is going to capture all of these measures. But as I say, we use self-report, we can use objective measure. But for example, Fitbits can be very successfully used as activity trackers. And the pros and cons of these different tools is that 6-minute walk tests can be affected by several factors, including age, gender, and weight, but it can also be affected by performance and learning. So we're more likely to do better the second time we do a 6-minute walk test than the first time, even if we repeat them on the same day. And self-report measures, there is no perfect self-report measure, but most of them overestimate physical activity. The only good news with self-report measures when it comes to things like that is that it's reliably over-reports. So if you're using it as a pre-post comparison, it's okay. But the weakness is, of course, they don't accurately reflect beyond the day-to-day, beyond the immediate test. So there is an opportunity then for our use of physical activity trackers. And what we found when we looked at this, and this is work by a student of mine, Mahdi Al-Harbi, was that they, in patients with cardiovascular disease, they overestimate the step count by about 13%, but it's within the acceptable limits. They overestimate moderate to vigorous physical activity by 10%, and they have a very high sensitivity to meeting the guidelines and a high specificity to meeting the guidelines. So wearables should be encouraged as tools that we can use to monitor physical activity. And again, we've looked at wearables in older adults, and a range of wearables are suitable for use in older adults and have been validated. And this work was led by Nicholas Straight and another student. So going to talk very briefly about other technologies that we might consider using in this population and people with cardiovascular disease in terms of detection of atrial fibrillation. So we have a range of different tools now available to us that we can use to detect cardiac abnormal rhythms. At the moment, the guidelines still only accept a single lead ECG of more than 30 seconds. So we still need to be using an ECG to do a diagnostic test, but we can use a variety of different tools to pick up atrial fibrillation beyond that, including blood pressure cuffs, which measure the rhythm based on 10 cycles of cuff deflation. There are a variety of single lead ECG devices, including the Cardio Mobile, Omron devices, the Apple Watch. We can also use photoplethysmography or PPG, particularly successfully used during the pandemic to monitor atrial fibrillation. And these are very useful adjunct tools to use with cardiac patients if there's any concerns there. So if you're considering using digital technology as in your practice, then the first questions you should consider asking are the sensitivity and the specificity of the test. If you're using wearable technology, is it CE marked for what you want to use it for? What are the costs that you might incur using this technology? Are the bits that are attached to it disposable or renewable? This is a really important question nowadays. Will it work in my area? How am I going to connect it to everything else? And what happens when I'm going to, once I've done the test, is there going to be a plan of action? Have we got the right care pathways established for this? So we are not well prepared as a workforce to work with digital technology. We don't teach people about technology in our undergraduate programs, and there's very little in terms of preparation for the workforce going forward. So we tend to see a diffusion of innovation curve occurring in the healthcare workforce, where we have the early adopters, we have the people who sort of adopt in the middle, and then we have the laggards who are quite resistant. And what we've experienced in our work is that the workforce sometimes have a lack of trust in new technologies, or they have poor experience with other technologies that have been introduced without necessarily a clear pathway of adoption. They may fear the pace of change and fear for their own work, and they may be unprepared to engage with technology. And certainly within the NHS, we have a lot of outdated technology. So we're bringing in these new tools, but then we have computers that take 10 minutes to boot up as we log on in the morning, and the tools may not be properly compatible. So we need to think, as people researching and teaching in this space, how we're going to support people to become accustomed to using technology. And of course, there's a high attrition from apps. So if you have looked at your phone, you'll see that there's a lot of apps on there you probably have only used once. Retail apps, those are probably our more popular apps. They open an average of 8.76 times a month. And there's an increase in things like ride hail, taxi apps, sport games, video and streaming apps. You probably use your bank app, not that infrequently, but health apps. And this is where I say caution with using health apps, because reported attrition is up to 98% with health apps. So we need to be very careful in the design and use of these. So again, just to say, by month 3, we've probably lost about 70% of users. It's a really big attrition in the early days of installing an app. So we need to be prepared for a future that has patient-centered digital care. And to do that, I think we need to build the technology around the patient journey and not the patient journey around the technology. The technology is already out of date by the time we're using it. There are things that are unimaginable coming along. So we really need to think, how are we going to adapt to using this technology in an effective and useful way? And really, we are now in a stage where we could use the Internet of Things to connect everything, but we haven't yet got there. And I think it needs a lot of investment and imagination to bring us to a stage that we're connecting everything in our lives to support us to live with better health, better energy consumption, looking after our security, and thinking about how everyday things get connected, developing smart homes and cities. It is the future. In some places it's there, but it does need some work to join the dots, and it needs some collaboration and cooperation. So with that, thank you very much for this invitation to speak, and I'm happy to take any questions.